of the world. So this is yet another global Isar Global Impact Factor. As you all are aware, these are a series of webinars that we from Isar, under the guidance of our President, Dr. Nandita Palshetkar, we've been doing since this year. We started in February 2023, and every month we have a paper which is recently published by a well-known and a scientist or a clinician who has published a paper recently, and we discuss that. We call in the authors and we discuss that paper, and they have, these impact factors have been very well taken and very well appreciated by all those who have been a part of it and all those who have been listening to it. So our President, Dr. Nandita Palshetkar, is not able to join today. But we all ISAR members are very well aware of Dr. Nandita Palshetkar. She's a IVF specialist with more than 30 years of experience. Apart from being the president of this huge body of ISAR of more than 6,000 gynecs practicing ART from India, she's had many important leadership role, and she's been the president of almost all major gynec societies in our country, and so therefore very well known to us. But she's not able to join in. She will join in as and when she is becoming free this afternoon. So let us go ahead and start our proceedings of this webinar. To start with, I would like to invite Dr. Monica Singh. She is from Bhopal. From Bhopal, Madhya Pradesh. She's currently the secretary of the MP chapter of Isar, and a very enthusiastic in academics and so many other programs that she's been involved in. So Monica, I would like to invite you to give a short abstract of the paper that Dr. Amal Driji is going to talk about today, our guest, whom I'll be introducing shortly. But you could just give us a short idea about what we are discussing today.
Thank you, ma'am. Thank you for inviting me. And greetings to our guest, Dr. Amal. Warm felicitation to Dr. Asha Bakshi, ma'am, who has joined. And thank you, Tech Support. Thank you, Sujata, ma'am, for this opportunity. Dr. Amal's paper is very interesting. It took me back to my second professional MBBS days, when inflammation was so simple. It simply consisted of calor, dolor, rubor, and we were sorted. But now Dr. Amal has brought out the concept of impaired inflammatory state of the endometrium. So what we call as endometritis, and we commonly label every patient as a case of chronic endometritis, has been segregated by Dr. Amal's paper into a set of either transient inflammation or persistent inflammation. In between, there is a state of repeated inflammation, and any case of chronic inflammation of the endometrium is susceptible to repeated attacks of acute inflammation also. Dr. Amal has beautifully brought out the etiological factors, and we only thought they were pathogens or germs or microbes, and we treated them with antibiotics. But so many of our patients who are treated with antibiotics, in India, it's a practice to give even, broad spectrum antibiotics. Very high antibiotics are sometimes prescribed for no reason. The patient does not respond. This is because the pathology can be damage. It could be trauma. It could be allergy. It could be, any small procedure done on the endometrium. It could be an autoimmune disease that the patient suffers from. It could be something like endometriosis or adenomyosis, which itself incites the inflammation. So Dr. Amal has taught us through this paper that segregate the patients into damage-associated endometritis and pathogen-associated endometritis, and accordingly treat them with the help of evidence-based therapy. The therapy should be very evidence-based, and there are only limited options. Antibiotics only when indicated, and I think she is not a very big proponent of antibiotic therapy. And she has given us a few hints about use of steroids, low dose aspirin, some non-steroidal anti-inflammatory drugs, even DHEA. So these are the therapies and these are the findings which are evolving, which are going to evolve in the next decade from Dr. Amal's paper. And I'm so happy to read it. Thank you, ma'am.
Thank you, Monica. That was excellent how you put the entire topic together. So now may I invite our guest today, Dr. Amal Driji. So she is an obstetrician gynecologist who practices in Algiers. Actually, we are virtual friends. We've never had the opportunity of meeting each other, but somehow both of us being passionate hysteroscopists and being part of different, the groups, WhatsApp, thanks to WhatsApp groups, we have known each other, and I have known greatly that the fact that she's written here that her special interest is in hysteroscopy and in the basic research on endometrium. I would go a step further and say that she's really, really passionate about the endometrium. And she's been an international author, speaker, and trainer in hysteroscopy. She's been a board member of the International Society of Gynec Endoscopists and member of the ISG Special Task Force on hysteroscopy. So today, Amal is going to speak about her paper, Impaired Inflammatory State of the Endometrium versus Chronic Endometritis. Amal, I invite you to share your slides and give us an insight into what your paper is all about.
Thank you. Thank you so much, Sujata. It's a pleasure seeing you. Thank you for having me here. And without further ado, we'll dive in the topic. I want to thank Dr. Singh for her summary. That was truly amazing. And now we will add further insight to it. So I have no conflict of interest to disclose. And so today we're talking of impaired inflammatory state of the endometrium, because there is also the physiological inflammatory state of the endometrium. So there is a physiological inflammation, which we will be seeing later. Where did the need of this paper come from my point of view, or from my end? It was actually, as Dr. Singh pointed out, that in practice, when we have our patients, we see that the chronic endometritis, germs, inflammation, antibiotics does not really work for many, many patients. And so we had that need to look deeper in this issue. And to do research, observation in practice is not enough. So we have to back this up with evidence. So before diving in the subject, I wish to start first with evidence. What is evidence-based medicine, with very simple examples so that it becomes simpler. So when we just take a simple example. I take a piece of sugar, I put it in a glass of water. The sugar melts. This is called an observational study. I observed a phenomenon. Case reports, series, cross-sectional studies, it's horizontal studies in a population. Now, if I take another glass of water and I put a stone in it, the stone does not disappear. This is a case control study. Now, if we randomize, which means we randomly put sugar or stones in glasses without knowing where we put what, and then we will notice that where we put sugar, it disappeared. Where we didn't put sugar, it stayed. This is called randomized blind RCTs. And when we methodologically analyze all the RCTs published in the literature, this leads us to the systematic reviews of RCTs and meta-analysis. So this is what we call the pyramid of evidence. There are also the cohort studies, which are follow-up studies, and at the bottom of the pyramid, the expert opinions. Now, the question when we have an issue that we want to discuss is, what is the best available evidence for any question? Most of us think that randomized controlled trials and systematic reviews are the highest level of evidence for whatever question. And this is actually not very correct. And to know better, we go to the fathers of evidence-based concept. Dr. David Sackett, who explained that very well in his paper published in the British Medical Journal in 1996. Evidence-based medicine is not restricted to randomized trials and meta-analysis. Actually, the randomized trials and meta-analysis are the best evidence for questions about treatment. For treatment, we need randomized controlled trials, but for a question on treatment where randomized controlled trials have not yet been conducted by colleagues, we just go and take the information from a lower level of evidence. However, for to assess the accuracy of a diagnostic tool, we do not need a randomized trial. We need cross-sectional studies. It's observational studies. Also, so we are here. This is the best evidence for diagnosis, not this. Also for prognosis. If you want to know the prognosis of the condition, we need follow-up studies. So we are here. We do not need randomized controlled trials. And as Dr. Sackett said, sometimes the evidence we need will come from the basic sciences, such as genetics or immunology. And our question as we are dealing with endometrial inflammation today is, what is the best current evidence regarding endometrial inflammation? So there was this author, Dr. Juan Espinos, who answered this question in a SWOT analysis, which is an evidence-based analysis of the strengths, weaknesses, opportunities, and threats of chronic endometritis. And in his analysis, he actually, this just to remind you that today, when I say chronic endometritis, it means chronic inflammation of the endometrium, which is caused by germs and which we treat with antibiotics. This is chronic endometritis. So in this analysis published in February 2021, they actually highlighted the inconsistent definition and discrepancy of diagnostic criteria. They also criticized the scarce knowledge of the etiology, because today, with the diagnostic techniques that we have, like PCR, we do not always identify germs in chronic endometritis. So other causes could also be implicated. And also they criticize as a weakness, the absence of randomized studies to assess the reproductive outcomes when antibiotic treatment is used. So this was published in February 2021. And in the same month, the first randomized controlled trial on antibiotics in chronic endometritis was published. And as you can read here, among subjects who attempted pregnancy, there was no significant difference in ongoing pregnancy rates and miscarriage rates between the treatment, antibiotics, and the control arm, no antibiotics. So the only randomized controlled trial did not support the effectiveness of antibiotics in what we term chronic endometritis. There were other RCTs, but actually this one was on the intrauterine infusion of antibiotics, same, not reaching statistical significance. And there was this recent systematic review and meta-analysis for impacts of oral antibiotic treatment on pregnancy outcomes in chronic endometritis patients. And also here, our meta-analysis proved that oral antibiotic treatment did not improve pregnancy outcomes in patients, because this systematic review did take into consideration the randomized controlled trials which were published from 2021. So as we do not have high evidence, or the only high level evidence for treatment is not supportive of germs antibiotics, all we have for chronic endometritis lies here. So we don't have really high level of evidence to support this concept. And this is where our work actually came from, these weaknesses. And so impaired inflammatory state of the endometrium is an evidence-based rethinking of endometrial inflammation, starting from basic sciences. Remember, sometimes the evidence we need will come from the basic sciences such as genetics or immunology. So why is it called impaired inflammatory state of the endometrium? It's because it's in opposition with physiological. Because we have to know that the endometrium is the place of a chronic physiological inflammation. The menses, the pregnancy, shedding, self-limited inflammation, regeneration. There's chronic inflammation going on there in a physiological way. There are tons of papers in the literature that highlight the inflammation, the physiological inflammation within the endometrium. So the inflammatory state of the endometrium becomes problematic when it is perturbed, and this can be either excess of inflammation or suppressed inflammation. This is a very interesting paper by Robertson in 2026, and they actually very beautifully explain this issue. It is well documented that any disequilibrium in favor of suppressed or excessive inflammation in the endometrium significantly affects fertility or placental morphogenesis. So both are problematic. And of course, germs being the only cause of inflammation is in violation with the basics of immunology, because in our paper, we have actually listed the available evidence in the literature that shows the impact of other causes than germs on the endometrial inflammation, oxidative stress, toxic habits, allergies, sleep disorders, stress, metabolic disorders. All these impact the endometrium, as Dr. Singh pointed out in the beginning in her summary. Adenomyosis, endometriosis, hormone imbalances, and of course, high doses of anti-inflammatory drugs. They perturb the normal inflammation within the endometrium and can cause the same complications regarding fertility, miscarriage. So regarding the discrepancy of diagnostic criteria, the International Working Group on Chronic Endometritis published in 2029 unified diagnostic criteria for chronic endometritis, and actually they listed micropolyps, focal hyperemia, edema, strawberry aspect, and hemorrhagic spots as significant signs for chronic endometritis. But again, edema, hemorrhagic spots, and hyperemia are the cardinal signs of acute inflammation, and this is known since the era before Christ. So they can be they can express actually acute inflammation, transient, but of course they can also be present in chronic inflammation, because chronic inflammatory disorder can manifest itself with acute episodes, repeated acute episodes. So we have also published another paper on the impaired inflammatory state of the endometrium more recently, and we actually wanted to work our way back to the basics. So we go to the basics of the endometrial inflammation, and from there we try to understand what's going on there to have more pertinent conclusions. So we focused our attention on the proliferative endometrium. Why? Because in the proliferative phase, this is when most of us do hysteroscopy, and also because the histopathological characteristics of the endometrium are simpler in the proliferative phase as opposed as to the secretory phase. This is the secretory phase. You have this table and this one. So it's every day with specific features. So it's more complex to correlate with hysteroscopy. And when we speak of histopathology, I wish you focus with me here specifically, because this is very capital, and I'll make it very simple. We have to know that progesterone and inflammation play a pivotal role in endometrial physiology. In the secretory phase, progesterone is secreted. What does progesterone do? Very simply put, it leads to recruitment of inflammatory cells, mainly the natural killers, inside the endometrium. And at the same time, it inhibits those cells. It stops their cytotoxic effect. When progesterone drops at the end of the menstrual cycle, the natural killers which have invaded the endometrium will resume their cytotoxic activity and will attack the endometrium, and so will the predecidualized cells. They will free their cytotoxic enzymes, and this is how the endometrium sheds. When there is inflammation, progesterone, there is resistance to progesterone. The receptors are not expressed properly. And when there are problems with progesterone, hormone problems, and progesterone is not properly secreted, there will be exactly the same consequences. This is why hormone imbalances are among the causes of impaired inflammatory state of the endometrium. And so if there are inflammation or parts where progesterone is not acting properly, there will be parts of the endometrium which will not shed. They will remain in the endometrium. And this has been actually described by the pathologists, and they definitely present endometritis can only become chronic if the endometrium does not shed with menstruation. So there will be parts of the endometrium which will not shed. Now, the good news is that these parts can express histopathological signs that we can see in histopathology. And this is why today, and since more than a century, pathologists have been highlighting the importance of stromal changes and epithelial changes in inflammatory endometrium, because there are parts of the endometrium which do not shed. There will be irregular, disordered proliferation, and the signs, the histopathological signs that actually manifest in this case, we have described them in our paper on correlations. And what we did was we took the histological signs of non-shed endometrium that we can correlate with hysteroscopy, so that we will do our sampling in these specific areas. And why not do cold resection of these areas? If they do not shed, maybe we can resect them, and this could be a future therapeutic perspective. So when we correlate the basics of histopathology, physiology, pathophysiology in hysteroscopy, this is what we can say. So we will, again, summarize. We know that impaired inflammation is more often focal than diffuse. So this highlights the importance of visual examination, not blind biopsy. Second, we always have to pay attention to the day of the menstrual cycle. There are a lot of hysteroscopists who do hysteroscopy and they don't even know when were the last menses. If we don't, we can never make the difference between synchronous or asynchronous endometrium. 3, for a matter of convenience, we chose the proliferative phase for the reasons I explained earlier. And there are actually 4 hysteroscopic signs that are significantly correlated with histopathology, with the basics of histopathology. The first one is the distribution of endometrial glands. All pathologists know that a normal proliferative endometrium shows normally distributed glands. Glands we can see at hysteroscopy, it's those white dots. Here we see that they are not distributed at equal distance. You see the distance is different. This is a sign of a dysfunctional inflammatory endometrium. And here we should do our biopsy. The second thing is the irregular thickness, because there are parts which did not shed, parts which did. And as you can see here, thickness of the endometrium is not the same. We can see it here. You see this area? And when we take a closer look, there are embossed patterns and there are debossed patterns. And this can be also observed in hyperplasia and in dysfunctional endometrium. When we look at this example, for instance, we get inside the cavity, we see this. Most colleagues maybe won't pay attention to this. But when we take a closer look, we see that the thickness is not regular, the distribution of glands is not either, and there's also hyperemia. So here we should take our biopsy. Of course, micropolyps everybody knows the pertinence of micropolyps. They were assessed by Ettore Ciccinelli, and he demonstrated that they are rich in plasma cells, in immune cells. And also the strawberry pattern, which was actually very well described by my mentor, Professor Bruno van Herendaal, many years ago, and is like, you see, an endometrium for the strawberry, normal, the same height of the endometrium with white dots at irregular distances from one another. So this is how the strawberry manifests itself. So these signs are very significant of dysfunctional endometrium, and these are what we will be assessing very soon in our multicentric clinical trial. Now, regarding edema, hyperemia and hemorrhagic spots, they can be observed in acute inflammation. Hyperemia and hemorrhagic spots can be normal in the early proliferative phase, and edema can be physiological in the mid-proliferative phase. But of course, they can also be associated with a chronic disorder. So we have to interpret these three signs with precaution. And I show you here an example. This is the same endometrium. This was at the beginning of the procedure, and this was at the end. And you see that there's edema, hyperemia, hemorrhagic spots. This is iatrogenic inflammation. This is not chronic inflammation. And there are traps, pitfalls to pay attention to, so that we don't mistake, we don't get misled. So iatrogenic inflammation we just saw. This highlights the importance of using small caliber instruments and examining the endometrium at the first passage, because when we get inside and then get out, it collapses. There is added inflammation. And so we have to assess at the first passage where to biopsy and where are the problematic areas. The isthmus. We published the hysteroscopic limits of the isthmus 3 years ago. And actually, there are two internal os of the cervix. We all speak of one internal os, but there are two. When we are careful to details, we can see them better here. You see? And this area is called the isthmus. If we do a biopsy here, the pathologist will tell you dysfunctional endometrium. But this is not dysfunctional. This is normal isthmic endometrium because it is poorly responsive to hormones. So we have to avoid this area if we want to assess the endometrium. This is not a proper area where to sample. And of course, in histopathology, we need to do a good sample, a good amount of tissue to never press it, conserve it properly. This is very important for the pathologist to be able to assess and work on a proper tissue. And for the future perspectives, actually, we question the pertinence of cold resection of the inflammatory areas based on the concept of non-shed endometrium. Of course, more studies are needed. This can be done with scissors, this can be done with graspers, or with the cold loop of a miniresectoscope. And I wish to share with you this paper, which was published this year in March 2023, and they actually assessed the gentle curating of the endometrium in women with antibiotic resistance to chronic endometritis, resistant to antibiotics. And so they revealed that actually the gentle endometrial curettage for antibiotic-resistant chronic endometritis significantly decreased the number of CD cells and resulted in improved pregnancy outcomes regardless of remaining CE. So even if there were CD 138, the outcomes was improved when they did this curating. I think better yet, do it under visual control, cold resection under visual control, and this is what we also will be assessing in future trials. But of course, we need more studies in this area. So never forget the etiologic treatment in impaired inflammatory state of the endometrium. We're not talking of antibiotics, germs. We have to investigate the patient, look for all the factors that provoke disturbance of inflammation in her case and treat them one by one. This is very important. So we can, if we do resect the inflammatory dysfunctional endometrium, if we do not install etiologic treatment, it will recur because the cause of inflammation will still be there. So that was what I wanted to say. In conclusion, today, the problem with chronic endometritis, as it is defined consensually today, is that it's in violation with basic sciences. And with our researches, we try to reconnect with basic sciences and build our strategies from there. And let us not forget that impaired inflammation is not just about fertility and pregnancies and babies. It's also the bed of proliferative issues. Excessive inflammation in the endometrium can lead to cancer, can lead to hyperplasia, polyps. So it is actually worth our attention and that we take it seriously. And for that, we have to start from the basics and work our way up to more pertinent approaches, hopefully in the future. Thank you for your attention.
Thank you so much, Amal. That was very insightful, and it was something so much that we learned. Now, may I invite Dr. Asha Bakshi? Can I have her CV, please? So, Dr. Asha Bakshi is the current treasurer of the Indian Society of Assisted Reproduction. She's the incoming Secretary General. Dr. Asha Bakshi, can I have, please? She's the incoming Secretary General of Isar. And before I introduce her, I would like to profusely apologize for the mistake that we've made in the flyer. Actually, Dr. Asha Bakshi is to give the summary and the question answer session. And Monica, so we've just exchanged the names. I am profusely sorry for that, and we have not noticed that. Really sorry for that. So Dr. Asha Bakshi is very well known. She's been the Vice President of the West Zone of FOXI. FOXI is the Federation of Obs and Gynec Societies of India. For those of you who are not aware, she's current treasurer. She's been the executive body member of the AICC RCOG West Zone. She's the founder chairperson of MP IAG and MP Isar, member of the advisory board of PSC PNDT of Indore, and she's got many awards and recognitions to her credit. The most important being that she's been the first ICSI TISA, I mean, she's been a pioneer in ART technologies of Madhya Pradesh, the recipient of a Kumud Tamaskar Award in FOXI 2008 to 2009, the best paper in FOXI Journal of 2011 and 12, and she is Padma Shri Dr. S.K. Mukherjee Award 2021, Excellence Award Dainik Bhaskar in 2021. So Asha, may I invite you to take this webinar further? What are your thoughts on Dr. Amal's paper? How do you feel this gives us a new thought process and new techniques to practice ART?
Thank you very much, Sujata, for this opportunity. And I would like to thank Dr. Nandita Palshetikar, under whose guidance all these things are going on. And they are very excellent and high level, I would say high quality webinar I've witnessed today. And it is really nice. And I must congratulate Dr. Amal for bringing out such simple thing and making us all think. And I think I'm sure you all will agree that we all always felt that there is something like chronic endometritis. We keep on talking and we keep on sending the biopsies for histopathology and culture, and hardly ever we find anything much. And many times we feel on hysteroscopy, it looks like that there is chronic inflammation, and you again send it for culture, there is nothing. Though PCR technology recently have these techniques have added a little bit, and they are able to diagnose few of the microbiomes with these molecular technologies. But still, everything is, we are all confused. Many times you think that hysteroscopic findings are absolutely normal, and then your reports come that no, there is something. So still, even with hysteroscopy is also not gold standard. So still there is a lot that needs to be done, which can really help us diagnose inflammation. And you took us to the basics, that what all changes in the stroma and glands and all those things that you see, and maybe some easier diagnostic tools need to be there that can help us in diagnosing inflammation. And one, your terminology of IISM, impaired inflammation of inflammatory status of the endometrium. I think this is excellent. This is a very good thought that you are talking about, that there is some inflammation, we all know, but it should not be too much and it should not be too less, and there has to be a balance in it. So that was a very good thought and very good terminology. This is a newer terminology, and I think we all should start using it. It's a very good technology. One question I wanted to ask Amal is that how are you diagnosing your these IISA in your day-to-day practice? What technology you are using?
Thank you so much, Dr. Asha. I would just like to bounce back on something you've just said, that hysteroscopy is not the gold standard for diagnosis of chronic endometritis. And as Sujata can guess already, I think I'm not really okay with this, because inflammation, and this answers your question, by the way, how I do this in my practice is exactly how I explained. I know the endometrium by heart. Like the tables I showed you, they are in my head. So we know that inflammation is more often focal than diffuse. What seems important is to do the blind biopsy that most IVF centers I know continue to perform, because as I showed you in the slides, sometimes the inflammation is just in a restricted area, and sometimes I remove it, I install an etiologic treatment, and we have actually better outcomes with these patients. Again, what I'm saying needs to be backed with trials, and we are currently working with a project of research to assess what I'm telling you. So what I do is I schedule the patient in the proliferative phase, and I always take into consideration the day of the menstrual cycle and the length, because later I have to know whether I was in the early, in the mid, or in the late to have the certitude. And I see with my own eyes at the first passage, not only the strawberry pattern and the macropolyps, but also those areas where the endometrium is not regularly thick, when glands are not evenly distributed. And this is where I will be taking the biopsy. My correlations with my pathologist are actually nearly maybe like over 90%, because the sampling is targeted. But what is often done in fertility centers that I have had the experience to see is that they enter with the diagnostic sheet. They don't even get an instrument with them when they do diagnostic hysteroscopy. They look, they say, oh, it's red. Oh, yeah, there's inflammation. They remove it. Sometimes they don't even take sample. They just put antibiotics. Some other times they insert a Pipel or a Novak, and they do blind. And when they take this sample to the pathologist says normal endometrium. Well, maybe they just biopsied a normal endometrium and not within the area. So the way we do hysteroscopy, oftentimes I have colleagues telling me normal hysteroscopy, but when I observe, I see a lot of dysfunctional anomalies that colleagues do not pay attention to. So we need to actually increase our knowledge, our education, because the endometrium is not easy. It's a cyclically changing mucosa, changing every 2 days. So it's not really simple. So the more we look into it and try to improve, I think the better our practice will become.
So
when
you
you're
said
taking
the
that biopsy piece, no, so it will be a very small piece if you take just with a grasper. So do you take with the scissors and take out a chunk, or how do you take that piece out? Because the fluid is flowing, and to bring that, I mean to say, intact is not that easy. So that's what I wanted to ask you.
Thank you so much. I love this question because that's actually a major issue. When I do the biopsy with the graspers, I do it like the polypectomy with graspers. I explain. I identify the area. I open the graspers. I put them at the base. I push. Then I come back again and I push, push until I have an area like this one, for example.
Flap.
I remove it, and sometimes I don't need to remove it. It just flows out, and I collect it outside the patient's body.
Yeah.
We can do it also with scissors, but we can do it perfectly with the graspers, but then just push and take an area.
Yeah, you
we
just
can do
lift out the endometrium.
Yeah,
That's
making a flap, making a small flap and then taking out.
Yeah,
perfectly that, yes. And sometimes I work with the cold loop of the mini resectoscope.
Yeah.
The mini resectoscope, I am fortunate to have one at my disposal. So you don't need dilation at all. It's like the talkies and the 5 millimeters. It's 5 millimeters or 6 millimeters and 1 or 2. And I get it inside without dilation, and I can actually do like a superficial curating, and I have more tissue to address to the pathologist.
Yeah, maybe endomorcellator
Stand for
may also help
histopathology?
in these cases. Those small morcellators that take out the polyp, no, debriders sort of thing. Maybe that would be also a good idea.
The true clear system, the morcellator, hysteroscopic morcellator, you mean?
Hysteroscopic, yeah. The debriders that they use, no, small ones. So maybe with that also you can get the chips. Yeah.
I prefer to have areas because then I have the superficial, the surface epithelium. And I haven't experienced that with morcellation. I prefer to have areas because they are easier to interpret by the pathologist.
So I had a question, Asha, for Amal. So do you send only for histopathology or immunohistochemistry also?
I do not do immunohistochemistry.
Because that seems to be so much in vogue now.
Yeah.
That people say that that's the way to diagnose.
Look, I will tell you a clinical situation I had experienced. A patient was addressed to me by a professor at hospital because in the fertility center where she was followed up, she had a hysteroscopy. They concluded chronic endometritis, CD138 positive. They put antibiotics 3 weeks. They did another blind biopsy. They found plasma cells, immunochemistry. They put other antibiotics, other biopsy, 10 times, 10 biopsies, 10 antibiotics. When I did a hysteroscopy, I found that she had actually fluid coming from the tube.
Okay.
Hemattic fluid coming from the tube. And she had endometriosis. So this woman will always have plasma cells because she has endometriosis and she has a toxic fluid invading her endometrium. What's the point of doing the biopsy over and over again and prescribing tons of antibiotics that will just ruin her microbiota? The American team of Dana McQueen in summer 2021, they actually criticized the concept of CD138 because actually it's expensive. And sometimes we have normal plasma cells in normal endometrium. So this team actually defended the idea of looking into the stromal changes. If there are no stromal changes, no epithelial changes, there is no point to look for plasma cells. But to objectively assess stromal and epithelial changes, we have to do our sampling within an area that displays these anomalies, because there we will find the changes. If I biopsy, if I have an endometrium which looks okay, and then there is an area which looks dysfunctional. If I take the sample elsewhere, I won't find the stromal changes. But if I take the tissue this is the idea of hysteroscopy under visual sampling, there I will document the stromal and the epithelial changes.
Right.
So I don't.
You need a histopathologist who has really keen interest and who really looks into that small piece of tissue that you have sent. So you should have a good rapport with your histopathologist, basically.
I love your questions because you're actually just adding all the things that I couldn't say in the presentation. My
She's very
pathologist,
practical about the problem.
yeah, she's like going like that, and my pathologist has become one of my best friends. And yeah, I chose to work with him at the beginning because I noticed he describes very well the endometrium. And I grew up thanks to him. And he says that he also grew up thanks to me because we work together and sometimes we disagree. And when we disagree, we always look for an explanation, and we often find explanations that fix the patient's problem. So I think that when we work on this area, we need to have a pathologist who is aware of that, because as you have, like, I thank you for your observation. Pathologists are just like hysteroscopists. Not all of them know the endometrium. Maybe most of them don't know the endometrium. Maybe the pathologist you work with has a special interest in the stomach or in the digestive. So we need to work with someone who knows the endometrium. And now, this is an area of special interest for me, when I have the report of a pathologist whom I'm not used to working with, I see how he describes, and then I can be sometimes critical, and then I call them and say, you said you wrote this, but this seems like there's a discrepancy here, and we discuss this, and then you know whether or not, like what credit to give to the information. We have to be critical. We don't have just to take for granted what pathologists write in their conclusions. This can be very misleading. I'm saying this on my clinical practice. If I weren't warned, many times I would have completely missed the point in some patients.
And I think another area which we have to think about is isthmocele, the iatrogenic problem. Because you described that area, the isthmic area. So many a times we may be getting more inflammatory cells from that area because of that fluid being entrapped in that area. So that also needs to be really looked into it, and we have to start describing the features of isthmocele also.
Yeah, I could not agree. I could not agree more. And isthmocele, I wanted actually to put it in the paper of impaired inflammatory state, but at that time I did not find actually literature to back that. But in my practice, definitely now when I have patients with isthmocele, if they are symptomatic, they have what I mean with symptomatic is the postmenstrual bleeding. In these patients, I treat isthmocele hysteroscopically. And when they don't have postmenstrual bleeding, and I look, diagnosis hysteroscopy, I see, sometimes you see polyps inside the niche. You see micropolyps. You see polyps, endometrial polyps, for a very long time were presented as due to hormone imbalance.
Hormonal imbalance, right.
But hormone imbalances cause impaired inflammation, as we saw. And the recent years, maybe since 5 years now, polyps are now more and more, we know that they are generated by chronic inflammation. Chronic inflammation causes endometrial polyps. So when I have an endometrial polyp, I have to look for other inflammatory signs and inflammatory context in the patient, etiologies. So when I have an isthmocele that shows inflammatory signs, I automatically treat it. I think that for some isthmoceles, they cause inflammation. Other times you have a niche which is completely fibrotic. This one, I won't touch it if the patient is not symptomatic.
So how do you treat your patients, Amal? You said you don't like, they are not very often caused by germs, and you don't believe in antibiotics. So I would understand that how you would treat is you would first try to find the cause of that impaired inflammatory state and then try to correct that cause, right?
Absolutely. So when I have the patient first contact, is I do an investigation where I look for all these etiologies.
Yeah.
I think because now I have some, it has been years since I've been working like that. So I see that the most problematic etiologic factors today is bad hygiene, stress, endometriosis, and adenomyosis. These are actually problematic. And what I also do, I do prescribe antibiotics, but short antibiotics, because I'm a scientific person. And I think that I don't have the right to experience new stuff on patients without evidence, without proving it before. So this is very important. I never do those treatment of 21 days and repeat it. It's not interesting, especially for the microbiota. It can cause the adverse outcome. I also do in my practice now cold resection. So when I do diagnostic hysteroscopy and I see those inflammatory areas, I try to resect them in an atraumatic way, cold superficial resection. And we have had a lot of patients who had sometimes 2 or 3 failures in ART and who then conceived spontaneously after cold resection and this etiologic treatment. I think it's really worthwhile it's really worthy of further investigation and further assessment.
Right. Asha, there are
One
some
more
questions.
question.
There are some
I will
questions
ask one
in
question.
for
I
the
think I've got
audience.
lots of questions, Amal. So one
Right.
more question. This theory which had started a few years ago is scratching of the endometrium before embryo transfer. So do you think, would there be a correlation between inflammation and endometrial scratch? Is there any, could there be a correlation there as well?
I thank you again for your question. Endometrial scratching, when it was conceived first by the Israeli, it was because they thought that there are patients who have low inflammation. So it's impaired, but it's low. So when they scratch, they provoke liberation of inflammatory parameters, which are useful. So this is the concept. As most hysteroscopists in the world, I tried scratching myself in my practice maybe like 5-6 years ago. I was doing scratching, but in my practice, I didn't find it actually useful, or I didn't notice any. It didn't better the prognosis, and so my experience is goes with the conclusions of the evidence-based medicine today, because the endometrial stretching today did not prove to be significantly effective in women. So I don't really, I'm not really for this practice anymore.
Asha, there are some questions by the audience. Just ask them. 1 or 2 questions.
Let me check.
And they are not there in the chat box.
Chat
They're
box,
there
I
in the
can't
chat
check.
box.
They're
They're
there?
there.
Okay.
I'll check on the phone, maybe.
Nice.
Ma'am,
There is one. What are the different modules to treat chronic endometriosis? Endometritis, I think by mistake they've written What are the different modules to treat chronic endometritis? Somebody's asked. And another person has asked, what, in your opinion, about hysteroscopic characteristics of endometriosis, adenomyosis, and what are our managements?
What are the different modules to treat chronic endometritis? Well, it's antibiotics. Chronic endometritis today is antibiotics. That's all. Impaired inflammatory state of the endometrium is what I have explained in this webinar, but I see that this question was asked before we started. So yeah. I hope the person had the answer in this webinar, because they asked the question before I started speaking. It was
correct.
Yeah.
Correct. So chronic endometritis, you treat by antibiotics.
And this is what we criticize. This is why we changed concept.
Correct. And if there is impaired inflammatory state, depending on what the pathology, what the etiology is, you try to treat that, right?
The way I said, like etiologic treatment, I put short antibiotic, and I also, in my practice, do cold resection, but this needs to be properly assessed.
Investigated. Right. Asha, you would like to wrap up? We have about...
Can I ask one question?
Yes,
One last
yes.
question.
Yeah.
Dr. Amal, have you correlated your findings of chronic endometritis or any sort of inflammation of the endometrium with the measurement and the status of the endomyometrial junction on transvaginal sonography? Because I am a very keen sonologist, so we have this now concept of EMJ, that is the endomyometrial junction. It is a very dynamic zone which is situated between the outer myometrium and the basal layer of the endometrium. So this is the layer which is affected first in endometritis, and it becomes irregular. And a sonologist with a good frequency, high frequency probe can discern the changes. So is there any possibility in the future where you'll be correlating your hysteroscopic findings, histopathology findings, and the findings on TVS of the EMJ?
That's very interesting. Are you talking of the junctional zone or
Yes, ma'am.
Yeah.
the
Exactly.
junctional zone?
Yeah.
Are you also referring to adenomyosis?
Yes.
Yeah, it's one of the key areas where JZ or junctional zone is disturbed, besides chronic endometritis, malignancies, even fibroid uterus.
I congratulate you for the work. This actually brings me back also to the question that was asked by a colleague, opinion about hysteroscopic characteristics of endometriosis adenomyosis. I'm an ultrasonographer too. I think that adenomyosis has already, when you read in the literature, hysteroscopy and adenomyosis, they always describe the inflammatory signs, like strawberry pattern is described as one of the signs of adenomyosis. But in my opinion, adenomyosis being an inflammatory condition, because it's the presence of an active inflammatory tissue outside where it should be. So it provokes inflammation, and in my opinion, this is what causes the inflammatory signs within the endometrium. I have a lecture on this topic, and I have also published a paper in the Trocar on the hysteroscopy in patients with adenomyosis and endometriosis, and I encourage you to read it. It's available in my ResearchGate account. I think that the junctional zone, I could be wrong, but in my opinion, it's more representative of adenomyosis. So adenomyosis is one of the causes of impaired inflammatory state of the endometrium. With the Belgians, and I also work with my team, Professor Bruno van Herendal, Dusan Djokovic, who is also an expert ultrasonographer. And with the Belgians, they wanted to develop some ultrasonographic tools to look into inflammation, also regarding Doppler. With the progress of ultrasonography today and the Doppler, maybe this could be an option in the future. However, I think that the superiority of hysteroscopy in this specific area is that we can zoom, we can see actually glands. We can also do sampling under visual control. We can see alteration in colors that, I don't know, maybe in the future we can correlate that with ultrasound. To date, it's not still the case, but hopefully, cross my fingers.
Thank you.
I hope I answered your question.
Yes. Thank you so much.
So I think we're towards the end of our webinar.
Yes.
We are a few minutes short. Asha, I would request you to wrap it up and thank our guests.
Thank you very much, Dr. Amal, for such a nice webinar, such nice discussion, and taking us to the basics. That is, I think, most important. And you made us think about so many things. which we were just overlooking the things. And I think you made us think in really very deep. So thank you so much. And thank you, Monica, for conducting the program. Thank you, Sujata, for the whole concept, and to Dr. Nandita Palshetkar. And I'm sure we'll have more and more programs like this. And Amal, we wish to see you in India sometime soon.
Yes,
Thank you.
you will now have to come physically for our conference.
Yes.
Thank you so much. Thank you so
Thanks.
much.
Thank you all, and thank you, Dr. Asha, for the pertinence of your questions. I really enjoyed them. Thank you.
Thank you. Thank you.
Thank you, Asha ma'am. Thank you, Dr. Amal.
Thank you.
Sujata ma'am.
Thank you.
Bye.
Thank you all. Bye.
Bye.
Thanks, Dinesh. Dinesh. Tech support.
हो गया
सो गया दिनेश ठीक है चल बाय कट कर